Yeah, that's true, but and you mean like an agenda invite, I guess.
The secretary centralized, I think. Yeah, maybe it's centralized. Yeah,
but that might, otherwise it might really be something to suggest again to make it. I don't know whether.
Yeah, they were already dying. Yeah. You can search your email.
Hereby, I open this academic ceremony in which Jennifer Klasen will defend the academic thesis Allowing Failure as an Unspoken Pedagogy in Residency Training. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you very much, dear Pro-Rector, members of the Assessment Committee, hi Doreen, dear supervisors, dear family and friends here and online. It is an honor and delight to be here with you and to present my line of research in the next 15 minutes. This journey actually started a couple of years ago while I supervised one of my fifth-year surgical residents during a minimal invasive surgery on a gallbladder. The resident was experienced in such procedures and I had supervised her a lot. She had been confident during the last couple of operations. We performed together and had no complications. This particular gallbladder was easy to resect, so I stepped back and let her operate. To give you a bit of a background, as surgeons, it may seem as a simple procedure, but you need to pull on that gallbladder just enough that you balance the tension and the exposure of the tissue. I warned her in particular, in that case, in advance and told her that she had to be careful with that fatty liver in that patient case because that fatty liver is vulnerable. At one point in this latest intervention, she grasped the gallbladder and put too much tension on the patient's fatty liver, and I could see that the capsule of the liver could be damaged and bleed. This time, however, I didn't warn her again. In just that second, I decided not to repeat myself and warn her again. I let her fail. I was in that situation deeply confident that she would manage the situation and stop this minor bleeding and the patient wouldn't be at any risk to any time. And what I expected actually happened. The capsule of that liver was damaged and started to bleed slightly. The resident was irritated in the first couple of seconds in her standardized procedure, but handled the situation very well. And the patient left the hospital after 2 days, as any other patient after such an intervention with full rehab, but left some question maybe for you now, reading my thesis, and back then for me, actually. Why did I decide to let her fail? When did I decide? in that situation to let her fail this time? How did I know that she would handle the situation, and if she was not handling the situation, I was able to do that? What is the potential of teaching and learning through such situations? To me, it seemed potentially problematic, but also very powerful. Driven by my curiosity, I started to have informal conversations with colleagues, and I learned that they allowed similar situations to happen. So maybe I might have realized the phenomenon in the clinical setting, which I didn't know of before. Based on those informal conversations, I developed the presented research program. To bring the phenomenon into the light in our field, I asked the questions: if such a practice of allowing failure during clinical supervision exists, when, why, and then how can we as clinical supervisors allow failure? And last, is the context of a specific specialty in which they work relevant? And what we focused on in the last study is a specific clinical context at one institution in the last study. So to answer the first question, we performed a literature review where we found that educational sciences support failure. Their educational activities are carefully structured to provoke learner failure in order to drive learning and cultivate resilience. Such research is coming from early childhood education, for example, learning sciences and higher education, for example, driven by Manu Kapoor, who promotes the so-called productive failure in different psychological and pedagogical areas, or business administration, suggested by Emmy Edmondson, whose research examines psychological safety and teaming in organizations. In the field of medical education, however, we didn't find any literature supporting failure or investigating the phenomenon of allowing failure. Nothing was known about, to my best knowledge, how we might translate this approach to learning in the clinical workplace. You could even say it was a taboo, or it is a taboo. To allow failure in clinical training might be problematic. And why is it problematic? The main reason for this literature gap in our field is that the education approach is unspoken, given our primacy of patient safety as an untouchable value in medicine, and that also trainees' well-being might be at risk when we use such a strategy as supervisors. As a consequence, to be honest, I realized early on that I was working on a topic of sensitive nature, especially as this strategy balanced trainees' learning with safe patient care. Our explicit conversations about this taboo triggered sensitive responses for grant submissions, sensitive responses in presenting this topic in front of an audience, and doubtful colleagues, and also my chiefs. And maybe you feel it right now again, or felt it while reading the thesis. Such responses reveal the cause why we don't talk about it, as I already mentioned. Allowing failure can be problematic on different levels for all the individuals involved. In 3, constructivist-grounded theory, supervisors from different clinical backgrounds confirmed to allow failure in a broad range of clinical performances of their trainees. From their narratives, we were able to define this phenomenon. Instead of providing you, however, with a definition, I would like to give you an example that you can better imagine what I describe. This is a shortened example coming from an obstetrician. She explained, "My newest example, which I had just a few weeks ago on the night shift, was the night shift with a junior doctor. In her 3rd year, she is quite confident in what she is doing. I asked her if she wants to perform a C-section. I saw when she opened the uterus, or when she just had done the uterotomy, I saw that she is really going inside with a hand in a manner I couldn't imagine she could ever get that baby out, so I let her fail. She didn't get the baby out, and I had to overtake." The reason why most supervisors allowed it is the educational benefit in order to allow trainees to develop their skills and error management strategies. It was essential to them that trainees learn from a situation that they have experienced themselves and know what happened and how to deal with such complications. Whatever supervisors allowed, many participants described their rescue strategies to prevent an allowed failure from having a greater impact on our patients than anticipated. One of our participants explained an example of his supervisor telling him, "Whatever you cut, I can fix it." You can imagine that quote is coming from an overconfident surgeon. In general, clinical supervisors served as a safety net during clinical supervision that could be invoked when needed. Overall, supervisors appreciate a moment-to-moment and often unconscious decision. They acknowledged that the threshold between patient safety and trainee learning is not very scientific and sometimes rather a feeling than a really conscious calculation, and referred to their gut feeling and instinct. The data revealed 5 main factors which influence the complex judgmental process of supervisors to allow failure or not. The trainee factors, for example, how experienced the trainee was, the supervisor factors, considering their abilities or their personal or professional stress level in that moment, the caregiver factors, for instance, parents in the pediatric setting, seen in our last study in a pediatric setting. The environment factors, for example, the workload of a busy emergency department, and last but not least, the patient's factor, also as well as the interactions among them. These factors are not discrete. The interaction between them make the phenomenon sometimes even more complex. However, we tried and simplified that as it depends on the situation. After exploring the phenomenon from supervisor's perspective, I thought it is crucial to change the perspective, and learn about the perception of trainees. Answering the questions of if and how they experience allowing failure in their training was necessary to ascertain whether such experiences have the educational benefit that supervisors anticipated in the first couple of studies. In this constructivist-grounded theory study, trainees reported that failure was a common and valuable experience during clinical training, confirming also the broader literature in medicine and medical training. Sometimes trainees recognized that supervisors anticipated and allowed failure to happen. During reducing fractures, as one traumatology resident described, during an epidural anesthesia coming from an anesthesiologist trainee. When supervisors debriefed failure events with trainees, their feedback, however, was just technically focused and future-oriented. They talked about how to fix the failure or how to prevent it from occurring again. Recognizing failure, but rarely having supervisors confirm that a failure was allowed or why, participants tried to make sense of such events on their own. Additionally, when they judge the situation that they have been allowed to fail, the interpretation of the event is colored by the attribution of supervisors' intent. The intention could be interpreted by trainees as constructive or destructive. Trainees' sense-making influences whether the allowed failure experience is understood to be, in that case, productive or even more problematic by the trainee. And this understanding shapes whether and what learning trainees perceive from such an experience. Of particular concern here is trainees' attributions of destructive intention behind supervisors' decisions to allow them to fail. Why don't we talk about failure in medical education more openly? Well, it may be a sign of known lack of candor in the feedback and also assessment culture, where supervisors avoid conversations that feel threatening. It may also reflect the concern of losing our face in front of patients and colleagues when we admit we failed as trainees, or even we allowed failure to happen as clinical supervisors. From my perspective, supervisors, peers, and colleagues should communicate more openly with one another when it comes to failed situation in order to realize the intended educational benefit of such an experience. The silence around failure and also of allowing failure might be even more problematic than the phenomenon itself, because we know that learning is strengthened when explicit conversations happen. My message is that we have to acknowledge that failure in general is inevitable and also a powerful teacher. Allowing failure to happen in clinical training can be seen as problematic, but has also the potential for learning and growth. Thank you very much.
Thank you very much for your presentation, very clear. We will now start with the opposition, and the opposition will be opened by the chair of the assessment committee of your thesis, Professor Desiree Joosten ten Brinke, Professor of Learning and Assessment at Maastricht University.
Thank you, Madam Pro-Rector. Dear candidates, I've read your dissertation with a lot of interest, and the topic of your research is difficult because of the ethical considerations, but it is also very innovative. It provides new insights and input for further research, and I think the research has the potential to impact professional culture in the workplace. And it's good to see that most of the chapters have already been published or are accepted for publication. Said that, I have also read this dissertation with mixed feelings, as you already expected, in line with what you describe as the delicate balance between two primary roles of supporting learning and ensuring optimal patient care. At one side, I see the added value of learning from failures, but at the other side, I had strong ethical doubts reading your thesis, always thinking what my opinions would be if I was the patient, but also knowing that working without making failures is not possible. A child only learns to walk by trying, failing, and trying again. It is known that children with curling parents become less self-conscious than children who get the chance to fail. Although your research is focused on allowed failure in the training context, my question is related to making failures in the normal work context. And you had it already about the culture and role modeling. All physicians are human, and all human make failures, in line with your 9th proposition. What is the acceptance of these failures in practice, and how open can one be about their own failures without losing credibility? And in this context, I'd like you to read your proposition 11 from the booklet.
The proposition 11 is you can choose courage or you can choose comfort, but you cannot choose both, is a quote by Brené Brown, Dr. Brené Brown.
Thank you very much. What should be done in practice to create a more comfortable culture in the workplace where courage is also shown to discuss failures or mistakes? So the end of your presentation was about the role modeling, and what should be the next step?
Highly esteemed opponent, thank you very much for that question. I tried already being that role model, not only with this research program. What I did already is, after learning everything through that research program, I developed a workshop at our university back in Basel, where it's called How Physicians Deal with Failure, where we work closely a week with medical students on that topic. I could also gain some attention from peers and other colleagues who are willing to share failure in that protective workshop, I would say, because it's a safe environment. I bring my own examples of failure, and also my colleagues provided that. We invited a life coach who supports that situation, which is one thing I've done. I was able to convince with that the University of Basel that I was allowed to give the first lecture for medical students in a big audience, which was just 2 weeks ago. And the medical students were that interested that they didn't want to leave. So I had to say after 10 minutes overtime that I have to stop now, because otherwise the university maybe complain that they need the room. But I felt that there is a need to talk about more.
Yes, but that are the students.
Students.
What about your colleagues?
And the same thing they ask me. It is nice that you talk in front of colleagues, but how do you handle this in the clinical environment? And I had to say that if the change is not happening, and we will feel that in the clinical workplace, I experience different situations in my departments. I had a culture where I didn't feel comfortable discussing failure in a morbidity mortality conference, for example. And now we have a better culture where I feel also better share failures and learn from them more openly.
Okay, and coming back then to that proposition, do you think it's possible for the future that you can choose both?
Yeah. So at the beginning, I felt very uncomfortable presenting my line of research. Now I feel more comfortable. So I have to doubt that it's not possible to have both.
And a final question on that. You have spoken to the students and they want to change the culture in the future. And what we know, if the students are becoming supervisors, they are adapting culture of their supervisors. How do you realize the new culture? How don't they come back in, falling back in the current culture?
I think you have to create evidence in that field. You have to provide them with the tools like speak up examples, how they can do that. And you have to be a role model. So always telling also to my colleagues, if you see something which is not quite right during surgery, please let me know. And I tell that not my residents, I tell that the younger students in the room, and I also say that to the nurses. And I think change is uncomfortable, but you will grow in that situation, and it will get more comfortable over time.
Okay, thank you very much. I leave it to this pro-director.
Thank you, Professor Joosten. The opposition will be continued by Professor Ballmer, Professor of Pediatrics at the University of Pennsylvania in the United States. Welcome, Professor Ballmer. The floor is yours.
Referring back to 2022, when I personally witnessed your enthusiasm as a researcher and your elegance as a speaker when you were presenting at the Rhine plenary here in the United States. That was the first time I encountered your research, but it was not the first time I encountered the phenomenon. As you know, I do a bit of qualitative work myself, and just not long ago, one of the fellow surgeons said to me, about learning to teach in the OR. It was really exciting because she said it takes a lot of magnanimity. I mean, you have to be willing to teach and not do it yourself and allow for mistakes to happen that you might have to fix, or maybe that you won't even be able to fix. So the phenomena is alive and well in the United States. Magnanimity could be defined as loftiness of spirit, enabling one to bear trouble calmly. Loftiness of spirit, enabling one to bear trouble calmly. And what I know of you, candidate, you are a magnanimous surgeon and scholar. And so my question, I suppose, relates to proposition number 1 about unpredictability. And I'm curious if you've uncovered or considered that when supervisors allow failure, might they have a secondary motive? And that is to assess trainees' awareness of their limitations and their willingness to ask for help. Is there a distinction between allowing them to fail for learning for the sake of learning versus allowing them to fail to assess their willingness to ask for help? Any thoughts on that?
Thank you very much for this question. From my perspective, you're aiming in the middle of something between, is allowed failure in that situation constructive, or is it destructive, as trainees experience that? If a supervisor is coming from a place, I want to teach them a lesson, it could be a gray area. It's going into the direction of, it could be destructive, and it's not what is productive. It could be even more problematic, but asking for help is another possibility, as you suggested. And I think we didn't explore that in detail, but it might be possible to show the what a resident is able to handle and where he or she needs help or could ask for help. Your question actually reminds me, and also that a surgeon talked with you about that situation. It reminds me of the Thesis model, how a surgical educator, it's a 4-step model, how a surgical educator teach in the operation room. And the first is show and tell. So, I mean, the resident is doing nothing than observation and asking questions. Then the second step, and I like that model, obviously, the second step is a help. But the third step then is stupid help. So the supervisor is not assisting with a smart help anymore. He is pretending he is a medical student, for example, not very experienced, maybe also clumsy. And in that third stage is playing, I let them fail somehow. It's not that unpacked, but here it is somehow. And the last step is they have to know when they ask for help, but they have to handle the situation in a general easy case by themselves. So this is going a bit into that direction, but also there in the third step, it's not unpacked if the resident, how the resident to know when to ask for help.
Thank you. Thank you. Well, a second question is about methodology. And I'm wondering what the conversation was. You certainly had a wonderful team behind you. What was the conversation to take the same set of data and do both content analysis and constructivist grounded theory? I would love to be a fly on the wall and hear that conversation.
Yeah, thank you for that question. And it's also a question that we had to answer for the journal we submitted it to. It was not our intention, to be honest, in the first place. So we collected the data, but we were surprised about the richness of the data. Maybe it was we stumbled across the phenomenon the first time and then explored it. And then we tried to understand every detail which was possible so that we could define the first time the phenomenon we explored in that situation. However, after that, we realized that there is still something in the data we weren't able to cover the first time, because this complex judgmental process, we couldn't even capture it in the first time. So therefore, we did a second analysis, what was, to be honest, not our intention in the first place. But the paper was too packed with, is that too honest? Sorry. Yeah.
Thank you. Thank you.
Thank you, Professor Balmer. We continue with the opposition by Professor de Carvalho Filho, Professor of Medical Education Research at University Medical Center Groningen. Thank you for being here.
Thank you, Madam Prorector. I want to start by, dear candidate, I want to start by congratulating your team for your thesis. And I want to register how I find it relevant that you did the PhD with such quality on the top of your clinical work. I can understand how difficult it is, and I just want to make it explicit.
Thank you.
I read your thesis with great interest, and I was also a little bit disturbed while I was reading it, and I felt really uncomfortable with several parts, not because of the quality of the work, don't get me wrong, but because of the ideas. And I think a good thesis needs to create that kind of feeling, right? Transformative learning starts with some level of discomfort. So thank you for that. My first question for you is, like, you talked about cultural change in your discussion now, and also in the thesis. And I want to investigate that interplay between education and cultural change. I think we live in an environment of, there is a culture of performance from primary education, secondary education, higher education, but also in Instagram, in social media, and all our social activities are permeated by that culture of performance. Then now the resident gets to your rotation and you say, you know, yeah, we fail, we can learn from that. And I can imagine that there is a cultural clash when we change the conversation. And then I want your ideas, because you have been reflecting on that for a while. How do we navigate that clash? How we make it meaningful for them?
Thank you for your question, highly esteemed assessment committee member. I think this clash sometimes is more experienced in my case, at least from a medical student's perspective, as a relief. That they have to perform, most of the time they are academically high performer. They are used to success academically, and they enter the residency and suddenly they realize, oh my God, I'm not that high performer maybe anymore. They are particular students, they will also be high performer in the clinical setting. However, most students will realize, oh my God, that is totally different than I expected. The situation is coming, and they often fail on their own. They are like little mistakes along the way during the day, but they will come bigger failures and they will be even more disturbed in that situation. So if you try and help them and support them in such smaller situations, they will be so thankful. And if you open even more the conversation that we are all human and failure is inevitable, they realize that in the situation and try to grow. We have done outside of this research program a study on failure to rescue. And residents, medical students, they are traumatized by such events. They're not even responsible for failure to rescue, but they are the first provider on that bed. But no one will explain the situation. They don't understand the factors. It's the first night shift, and we leave them alone in the hospital. So, I mean, that is even up for more discussion from my perspective, because it's even more dangerous than allow them to fail in a clinical situation and then debrief somehow, because there is a conversation happening. Yeah. Often in the clinical setting, they are more or less alone.
But now these young resident graduates and goes to work in another place, and you are not there anymore. And the culture is still the same culture, right? How can we equip that person to expand the change that you want to see? And that's why I'm asking about the role of education in that, right? Because it's not only about the present, it's also about the future, and the future is sometimes in different places than the ones we were trained. How do you see that?
To be honest, I don't have a clear answer for that. I guess we need more research in specific types in that area. At the moment, I see my own work or my own presence in the clinic sometimes as a little spread. And then hopefully, if they experience such a situation, they give it to the future medical students and then to their colleagues. And it's like you give them a little fire and it spreads as a big fire. That would be a hope at the moment, but I don't have the answer for everything at the moment.
Maybe we need in the future to reflect also about how to make it a structural thing, not only an individual thing. That's a little bit because why I'm asking that question as well. And after reflecting, so my second question, after reflecting a lot why I was feeling uncomfortable while I was reading your thesis, I had the understanding that I missed the moral reflection about, because one thing is normalizing failure, another thing is allowing failure. Those are two different things. One is fate, the other one is a decision. And it's a moral decision because you have to balance different values. And I missed that kind of reflection when supervisors and residents were talking about it. So why? Why the moral reflections are not there? Why is it not explicit to talk about what's right or what's wrong, and when it's right and when it's wrong? Tell me, I'm very curious.
I have to be honest, that is one of the little things I missed, and I have a bad conscience about it, or I feel sad about it because I missed it somehow. I talked with some of the supervisors about the ethical considerations, but I think because it was the first time more or less to have these official conversations about the phenomenon, then there was a lot to cover. However, I would have maybe had the opportunity to talk about it in the discussion, but I focused on the ethical part, which is for me more the professional side of the phenomenon. If you say moral, I would include the society, and what does that mean for our interaction between the society. And sure, if you have patients and you would say, or the community out there, and you would say you could be the patient like in every other minute, then there could be a trust issue from the society out there, and that would be problematic. So I think in general the conversations about failure has to lift somehow, and also the transparency, because that is what the literature say. If we talk about with patients more transparent, sometimes we will be even surprised how open-minded they are. When you try to hide something and they realize it, and that destroys even more the interaction between the physician and the patient. I think to overcome that problematic issue and I think that's one of my propositions, that we are also human, we make mistakes, and we are not even allow our children at home to make mistakes. We have to allow somehow our residents also to do mistakes and then try and support them in that situation. Probably the patients would be even more safe with us during that situation.
Thank you very much, Madam Prorector.
Thank you.
Thank you, Professor de Carvalho Filho. The opposition will be continued by Dr. Valkenburg van Iersel, medical oncologist at Maastricht University Medical Center.
Thank you, Madam Prorector. Dear candidate, first I want to compliment you and your team for this excellent work. I thoroughly enjoyed reading your dissertation. Among many other things, you achieved two remarkable things. First of all, you managed to rigorously explore a clinically very relevant but also very sensitive topic. Secondly, a more dubious honor, but your thesis was the first in many years which led to a kitchen table debate with my husband, who is a gynecologist also involved in residency training. I will not repeat the discussion here, but we both fully acknowledge that we allow our residents to fail on a daily basis. And this was also essential in our own professional development. I think in chapter 1 you reflect on your desire to persuade your surgical tribe, but you've persuaded a medical oncologist and a gynecologist, for now at least. Having said this, I would like you to read Proposition 8.
If you are not failing, you are not learning. It's a quote by Manu Kapoor.
Yeah. And I think as both a mother and of 5, and as a vice head of the internal medicine residency program, I wholeheartedly undescribe and agree with Manu Kapoor. But in view of this statement, I was very interested in chapter 1, you refer to the challenge point framework, in which you suggest optimal learning occurs when the level of challenge matches the learner's current ability. But after reading your work, I'm very interested to see what you think about that now when you look at that.
Thank you for your question, highly esteemed opponent. If you are not failing, you are not learning. Manu Kapoor is pretty famous for his research on productive failure, so such a quote is easy said and then explained by others. I think there are other ways to learn, don't get me wrong, but failure, as I said, or as I have written, is a powerful teacher. And thank you for acknowledging that. Sorry, can you repeat the last part?
What I was interested about, because the challenge point framework, it suggests that it should match. And I think when you're allowing for failure, and if you think failure is essential to learning, then you're not matching. I think you should challenge.
I think there are different concepts, and this concept is aiming for that level. But productive failure, for example, is aiming in the case, for example, for math students, that they are not able to achieve the task. So it's not a desirable difficulty as described by this concept. But for example, productive failure by Manu Kapoor, they will never achieve. Maybe you have a high achiever, but normally the students won't achieve this task. I think in our case, in the medical environment, it is possible that they achieve the task. Sometimes maybe not on that day, but they would on another day. So they handle different situations differently, not really matching the technical skills. So you can't always predict in a clinical setting if they would handle the situation. I also had clinical supervisors who anticipated they will fail in the situation, but got surprised by the resident how suddenly they solved the problem. So against their anticipation. So there is this unpredictability that they always solve it, but they should sometimes handle it too.
I agree. I want to move on to your definition, which you developed during the course of your work for allowing failure. And I think you refer to the sensitive nature of the topic, and you describe yourself language and definition is crucial. But then to me, it seems like you've chosen, despite that you've interviewed non-surgical participants, but you interpretate the data from a very surgical perspective. And I'm a medical oncologist, so it definitely triggered me. And I think this surgical perspective, it surrounds very heavy supervisory control in residency. It implies a lot of direct supervision. It implies that mistakes are there. Well, in my field of work, there are a lot of shades of gray, and I think nearly all training and supervision is indirect supervision. And I think full control of mistakes and failure is a complete illusion in my setting. So I'm wondering whether, with this very narrow definition, the impact of your work is not negatively influenced.
Thank you for that question. That's a very deep reflection about the definition. Yes, it is surgical influence because, as I wrote in the reflexivity, I can't deny and it's embedded in the methodology we used that I reflect. I'm a surgeon, and this might be influenced by it. However, I think we had clinical supervisors also, for example, in the field of medicine, so I had to smile while you said it. There is a gray zone. Is it even a failure? Do I sometimes allow a bit of a wider range of a possibility? And the next one would say, yeah, it's definitely a medical error. So there is the definition also. Is it problematic, or is the term even right? I'm not even convinced until today that we choose it right with the best interest. However, there is a lot of work what has to be done.
Thank you.
Thank you.
Thank you very much, Dr. Valkenburg van Iersel. Then the opposition will be continued by Dr. Meeuwissen, resident of internal medicine at Maastricht University Medical Center.
Yes, thank you, Rector. Dear candidates, I too want to congratulate you and your team with your fascinating work. And when I read Proposition 11, we just heard it, you can choose courage or you can choose comfort, but you cannot choose both. I actually first had to think about you as a researcher, because I can only imagine the many hurdles you had to overcome. And as a peer researcher, I can only admire you for that. So compliments.
Thank you.
My first question is actually about also a beautiful cover. It's showcasing kintsugi, Japanese art in which broken ceramic is repaired using gold. And I love the metaphor with failure, because it says that instead of hiding the cracks, it transforms damaged artifacts and in this way appreciates the whole as a valued part of the individual history. That's what it says. I've only seen this once in my life, and that was when I was visiting the property of a friend, and that's a very wealthy friend. And I kept having that in mind, and therefore I started wondering whether allowing failure for educational purposes is also something that's only there or meant for the sort of the lucky ones, the lucky few maybe, the lucky residents in this case who just come across a supervisor who is able to allow them to failure and also has the ability to debrief and have constructive learning conversations, and the lucky resident who is reflective enough to learn from that. So I'm looking forward to hear your reflection on this, whether you agree, and if you agree, whether you believe it should be available for all, and where should we start, because we don't have you in our clinic.
Thank you very much. I'm a bit blown away because I never heard that a resident could be lucky experience that phenomenon. It was often the other way around, that people approach me and saying, how can you do that to your residents? They already fail enough, and now you send them off to failure. So thank you for that new perspective. I'm not sure even if with the intention of some supervisors in mind, and now I want to for once critique allowing failure. I have seen such destructive intentions coming from supervisors, and then you are not really the lucky one. You are that resident who is targeted in that morning to get blamed, and I want to avoid such situations from happening in the future. I don't want to see it again. So if allowing failure would be used in such a manner, it was used in such a manner, then it is problematic. If it's with the best intention, maybe then the resident is lucky. I'm not allowed to say, or I wouldn't allow myself to say, hey, go to your institution and let your residents fail. I try to give you some reflections about a phenomenon which is described already in different educational approaches. For example, in the model I mentioned before, for example, in the adaptive expertise, there is somehow a bit of allow mistakes in it. So I think in general we have to open more the conversations about failure in general, but also about such uncomfortable phenomena, to have explicit conversation happening between patients, residents, students, and also with our chiefs.
Okay, so that could maybe help having all happy, lucky residents, right?
No.
Oh. Yeah.
If you have the residents in mind who actually explained examples where they are blamed because they did a mistake and they were sent up from the supervisors because they were lazy to get up during the night. Even the residents told them, I can't handle the situation. Oh yeah, you will do it. This is problematic.
Yeah. Okay. Yeah. Can I ask another small question? So the other question is actually about something totally different. It's about chapter 2, your review, in which you describe that most medical errors happen during the first years of residency. And in the Netherlands, there's a recent debate again about the fact that we have a system in which, and you referred to it a bit earlier, the fact that our youngest residents actually take care of our most ill patients, and also more experienced residents, but also consultants, take care of less ill patients, mostly outpatient clinic. And I was wondering, given your expertise, how you think about this structure, both given the fact that more medical errors happen, but also whether we can actually allow failure in this system.
I think two thoughts on that. The first is there is a description of that phenomenon happening. Not every study who explored the so-called Black Wednesday in the UK or the July effect in the US, which is defined as the rotation. In the July is in the US, where residents enter a residency. It's a July effect where adverse events rise. And in the UK, our colleagues with a bit black of humor, they call it Black Wednesday, when the rotation starts. So there are explorations confirming that adverse events rising. Not every study could show that. However, I think it is problematic to send out the youngest also during the night shift where really no one is around. In our country, no one really talks about it. So you are a step ahead of us in that situation. I think it is problematic, so we should be more hands-on in the situation. And I think that competency-based medicine tried to not really solve it, but lift that situation for us after that adverse event in the US happened, where the youngest of the teams covered a very sick teenager and died under their watch. So I think it's not to blame the youngest in the team. you have to talk to the supervisors.
Okay. Thank you. I'll give the word back.
Thank you very much. Then we already come to the last opponent, Dr. Stahlmeier, Associate Professor of Health Professions Education at Maastricht University.
Thank you, Madam Pro-Rector. Dear candidates, I join my colleagues here today in congratulating you and your team with this thought-provoking work. I've never read a thesis that was so heavily annotated by the time that I ended it, and it was not because of mistakes, but because it was raising so many questions, so many thoughts for future research, so many, but what if? And I was thinking of previous work that a PhD student of mine did that found that the safer the learning climate, the more adverse events. So I thought, oh, was that the explanation for what Alina Smirnova found back in 2018? So many thoughts, so little time. I'm going to focus on a couple of the things that were itching me. One is a tension that I noticed in your thesis between talking about it and not talking about it. There is this tension between wanting to formalize it, not wanting to formalize it, all the backlash that could give. And we know that there's a lot of power in language. You've already mentioned it today. So I would like to invite you to be a bit more explicit about the language that you found through your research. So which language have you found that may be constructive around this phenomenon? What language may be destructive? And what language do you think we still need?
Thank you very much for that question, highly esteemed professor. That language matters. You have to learn as a PhD student if you are covered by Lorelei Lingard as a supervisor.
Really?
Also, being a non-native speaker makes this even more complicated, to be honest. However, I tried, but not from the beginning. We noticed that searching for the right term, error was kind of captured in the patient safety literature. Failure was coming in, to be honest, a bit handy with productive failure from Manu Kapoor. Amy Edmondson used failure. So it was a bit, at the first glance, it had a very well connotation, reading and knowing that literature. Then I presented that talk in front of an audience where afterwards I had to go into the office of the head of the department where we had to search what failure means. Pretty stupid of me that I didn't do that up front, because failure also as a clinician means something very bad, because if an organ fails, the patient will die. And the industry used catastrophic failure, and then the world is almost at end. So using that term was kind of problematic suddenly, if you're not knowing the pedagogical literature. So I always, through the whole research program, we struggled finding the perfect term, and we are not at the end, to be honest. I don't know if failure is the right term, but to me it felt somehow comfortable knowing that literature. And being a non-native made it maybe also a bit easier, because I'm from a German background. We have Fehler, and that's all. Yeah. Fehler is the little mishap, the big medical error or adverse events. We don't have that balance in our language in that situation. So I think there's a lot of work to do at both ends. So working on a more comfortable term in our area, in the medical education scene, working in an English language, but also in my own situation. So for example, in my workshop with the medical students, or in that lecture, I say, hey, we have Fehler in German, but there is a whole literature suggesting other terms, and educate them about the definition, and when is a mishap just a little something you don't care about. What is a near miss with a problematic outcome, but it didn't happen, a medical error, a failure. So I try to get them sensitive about while reading and exploring the situation.
Yeah, what I'm hearing you say is the nuance and the context specificity of this, and that there's no one size fits all.
Yeah.
And you have to have those conversations again and again and again and again.
Yeah.
In our final minutes, I would like you to reflect on those struggles you've had with the ethical sides of things. You very clearly, in your reflexivity, talked about the various struggles you had with the various people. One of the actors that you could have struggled with that you did not talk about was the IRB. So my question is twofold. What was the reaction of the IRB, so the Ethical Review Boards, on your research? And what would you tell the Klasen Research Lab to kind of navigate this journey perhaps a bit more smoothly in future?
Thank you for that question. So I sent 2 different RABs, one in Canada and one in Switzerland. You can't compare both because to get ethics in Switzerland is probably the easiest job doing qualitative research, as long as you don't involve patients. If you ask medical students, you pay your fee and you are good to go. It's a bit almost too easy from my taste. We did quite an intensive job on the REB in Canada, but we didn't have a problematic issue from that side, hey, you allow failure. So I think it was the difference. I'm not going there and suggest, hey, would you allow failure, or please allow failure. I approached them asking about, did you ever allow failure? We also did a REB in the US, sorry, I forgot. So that wasn't an issue to get the REB. The issue was, the biggest issue was for me, or the grant submissions reviewer, very strict, and also my surgical chiefs, the most challenging opponents.
Well, I'm sorry that I have to interrupt this interesting discussion. Jennifer Klasen, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense, and I request that you and your company await the results of our deliberations and our return to this room.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
10 Minuten, 15 Minuten.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. Southside, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side. 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Frau Stolz geplatzt.
Aufstehen.
Jennifer Klasen, the degree committee here present has assessed the quality of your thesis and of your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Driese is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Okay. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Jennifer Margaretha Klasen, the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, I now present with you, and it's a primeur, the first gender-inclusive degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Dear Dr. Klasen, dear Dr. Klasen, dear Jen, congratulations on your doctorate degree. On behalf of your supervisory team, Eric Driesen, Pim Teunissen, and me, it is our pleasure to reflect for a few minutes about your PhD journey and to help you bask in the glow of this accomplishment. Our lives are unpredictable, beautiful, and surprising, challenging, even chaotic. So when we achieve a major milestone such as this one, we must pause to reflect. Indeed, to revel. You've done it. And it has been such a pleasure and an honor to work with you during this doctoral journey. We are so proud of what you have accomplished in these 5 years. 5 years, is that all? It's hard to believe that I only met you in 2017. Honestly, it feels like a lifetime. We had our first direct conversation because of your pepper allergy. When I took you to the cafeteria to get something you could actually eat during a master's trip to Canada. We had our second conversation the next day. I made you cry, remember? Not because I disagreed with your proposal to create entrustable professional activities for bariatric surgery, but because I interrupted you to ask a question you said you'd never been asked before. I asked you what you were really passionate about researching. And you told me, with tears in your eyes, a story. A story about a surgical resident. The story you told today. A resident whom you had allowed to make a mistake so that they would learn a pivotal lesson. You talked about how fraught and ethically complicated that decision was for you as a supervisor. And from that moment on, you have single-mindedly pursued a careful study of failure for learning, in spite of scholarly resistance, political minefields, and the sheer terror of doing justice to such a provocative, high-stakes issue. So, an inauspicious beginning, perhaps, to make your student cry in conversation number 2. Happily, though, we rounded out your supervisory team in 2018 with Eric and Pim, smart and supportive scholars who've never made a graduate student cry. And thus, you are on your way with a strong PhD proposal. You conducted 5 research studies about this phenomenon of allowing failure for learning. You explored how supervisors judge whether to allow failure for learning and how trainees experience allowed failure from their perspective. Your research was international. It crossed multiple clinical specialties. It culminated in insights that are relevant globally. It's what we hope for in a doctoral thesis. The impact of your work is obvious from your impressive publications in highly regarded peer-reviewed journals and the invitations you have received. Most notably, as a keynote presenter at the International AAMC RIME meeting 2 years ago. From your first conference presentation, which I remember to be about 4.5 years ago, you quickly learned, as you said today, that you are not the only one who's a little bit passionate about this topic. Your work inspired passionate responses in audiences everywhere you went. Unfortunately, there were 2 camps of passionate response. Those who passionately believed that this was at the heart of trial and error pedagogy in clinical apprenticeship, and it should be thoughtfully discussed. And those who passionately believed that it was an unethical, immoral educational practice and ought never to be spoken of. Often, those 2 camps were in the same room. We, as your supervisory team, began to realize that you were studying something that the community found to be taboo. And it stirred up very strong emotional responses in audiences. It takes courage to pursue work that provokes strong emotional responses. And you have repeatedly demonstrated that you possess not only that courage, but also tenacity, diplomacy, and grace under fire. For us as supervisors, though, this was kind of a unique challenge. How could we support your development as a researcher, our primary job, while also helping you safeguard your reputation as a surgeon and your well-being as an emerging scholar in the field? You even, as you've said, had to navigate tricky conversations with your surgical chief. Someone once told me that the worst thing that can happen to a researcher is to have your work ignored. That any kind of attention is good attention. But I think there were some days when you might rather have been ignored. We certainly, as supervisors, had to stretch ourselves to advise you to safely navigate those strong emotional responses that your work provoked. The 3 of us have supervised many clinicians doing doctoral work. And in our experience, the doctoral research usually takes second place. That's not a criticism, it's just usually a reality. The clinical identity, the clinical commitments are prioritized, and the doctoral work happens around the edges of that central identity. But you have been different. Yes, sure, you're a successful young surgeon who just delivered her habilitation lecture a few weeks ago. Congratulations. But you have also committed yourself 110% to this doctoral journey. As just one example, you quit your surgical job in Zurich, Switzerland in 2019, coming to Canada for a 9-month visit to immerse yourself in the analysis of your first qualitative interview transcripts. I was amazed by this decision, and I will confess, just a little bit worried. After all, even a very good first doctoral paper does not pay the rent in Zurich, Switzerland. But you were determined to meaningfully engage in the process of becoming a qualitative researcher. You were not going to be deterred by silly things like job security and economics. That determination has paid off. I don't say this often, but you are a rising star in the field. Of course, your determination and tenacity is balanced by other qualities. For instance, your impatience. Perhaps it is the surgeon in you. You want things done decisively, promptly, and preferably in a linear way. Your studies proved that clinical supervisory decisions about allowing failure are not linear, and I think your research journey has taught you that scholarship is rarely linear as well. Analyses get refined over and over and over again to move past the concrete to the conceptual, and some moments, when we're lucky, to the inspirational. And writing, well, writing with me as your supervisor was surely a test of your patience. We both lost count of how many drafts you wrote of every paper and how much writing feedback you absorbed. I'm quite sure there were many times when I sent more feedback about more revisions that could be made, and you just wanted to submit the damn thing already. You stuck it out, though, and your lovely thesis is a testament to that patience and the process. We are appropriately focused on you today. This is your accomplishment. But of course, you have not walked this path alone. Where would you be without Ola? Ola, who is the string to your kite, keeping you anchored while you fly. He even supported that crazy decision to quit your surgical job. And your talks, let's face it, wouldn't be nearly as beautiful without Ola's visual eye helping you. You have also had the support of your parents along the way. Karen und Hans, ihre Tochter, erreicht heute einen wichtigen Meilenstein in ihrem Leben. Es ist wunderbar, dass Sie hier sind, es mit ihr zu feiern. Und natürlich, Jen, hast du Frieda, deine Tochter, meine Patentochter. So schön, dass sie heute deinen Triumph sieht. Congratulations, Dr. Klasen. And now, let's go revel in your achievement.
Dear Dr. Klasen, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. I also congratulate your family and all that have contributed to this successful PhD trajectory, your supervisors from Maastricht University and the University of Western Ontario in Canada. I'd like to thank the members of the degree committee here present and online. Thank you very much for devoting time and expertise to make this PhD ceremony successful. I'd like the discussions you had with the new doctor. I hope you also liked discussions during this ceremony and go back to Switzerland with good memories of Maastricht. And with this, I'd like to close this academic session.
Thank you.
No, okay.
Recording stopped.